All right, good afternoon. I'm Suparna Bagchi, and I lead the HAI data validation activities within the protocol and training team. I know it's the end of the day. It's been a long day with a lot of information. And I'm glad actually that we started the day with the CMS presentation where my colleague from CMS actually touched upon a little bit on internal validation as well as the CMS validation methodology. And all of you have been actually getting throughout in the last couple of days a lot of subject matter information on each of the HAI metrics, data analysis. I'm going to start by saying that it is the end of the day, but all of that hard work that each of you conduct at your facility is meaningful when the data quality is high. Otherwise, it's all questionable. So over the next 1 hour, I would get your attention, if I can, to let's talk about data quality, and because it is critical for every work that you do and in general HAI prevention at your facility. So here's a broad outline of what we will talk about in the next hour. So we would start with reviewing the attributes of a high-quality HAI surveillance. We'll talk about what is internal validation and why it matters, and I'll end with, throughout the presentation, I would provide several examples of common errors, as well as provide recommendations of what you can do at your facility to achieve a very high data quality. So similar to the other surveillance systems, healthcare-associated infection surveillance is an ongoing systematic collection and analysis, followed by interpretation and timely dissemination of HAI data, which are essential for the planning and prevention measures. A good quality HAI surveillance system requires that it should be simple, objective, flexible, ensure high data quality and acceptability. It needs data accuracy measures like high sensitivity and a positive predictive value. It should be representative of the population under surveillance, and the information generated should be timely and stable over time. In today's discussion, we will focus on data quality. So data quality of the HAI surveillance refers to the consistency and validity of the data. So what we mean by consistency of the data refers to the data completeness, timeliness, and having confidence on your data. Whereas validity refers to the accuracy of the data, which means that when you classify an event as a positive event, that it is truly a positive event, and vice versa, that if you conversely, when you call it a negative or not a case, it is truly not a case. These attributes of data quality can be achieved by the data validation process. So why would you even want to validate your data? Simple answer. With all the efforts that each of you put in at your facility for HAI prevention, it would definitely help you assess whether the prevention efforts are effective at your facility. It gives you the confidence to hold up if there is an external scrutiny. For example, an external validation is performed by the State Health Department or CMS. And interestingly, you would be surprised at sometimes what you find. You keep on consistently doing something, whereas you don't check that what was wrong or whether things were being done correctly. Some of you might be already familiar with this. There are two types of data validation in the HAI field. First, the internal validation, which is generally built in as a routine process at the facility. This process assures data completeness and consistency of the NHSN data that is reported by your facility. The second process is the external validation, which involves a survey and an audit process and is always conducted by an external agency. This process is much more labor and resource intensive. These two types of data validations are interrelated. Once you continue to perform regular and ongoing internal validation, overall, it'll improve the data consistency, completeness, and timeliness, and thereby improving the data accuracy over time. So what would, in general, internal validation provide you with? It helps in identifying where are the systematic weaknesses in data reporting and how could you correct them. I'm going to repeat this again throughout my presentation, that you would definitely get from this completeness, consistency, and timeliness. It will assist in building coordination between partners and stakeholders, and overall build confidence and ownership of your own facility data. So if you've never had a chance to look at what this guidance is, where it is located, I know Henrietta earlier this afternoon during the lunch hour pointed out a little bit about where to find the data validation guidance, and I'm going to talk a little bit more about it. Within the CDC's NHSN validation tab, you would look for the internal validation guidance and toolkit, which is what I'm going to be talking about for the rest of most of the presentation. In addition to the internal validation guidance, we also have the external validation guidance and toolkit, which is used by external agencies when they validate your facility level data. And I know during lunch, Henrietta did point out that the resources within each of these consist of the manual, and you can always go back to the previous years where each of those validation guidance are included. They also can include within the resources tab the manuals for each of the specific years. So what does this validation toolkit, the internal validation toolkit, consist of? It provides you with the step-by-step guidance and recommendation for the facilities on how to plan the internal validation activities. This also includes various surveys with answer keys, which can be implemented at your facility to learn about the current surveillance practices, as well as to be able to identify where are the gaps in the current data reporting and where is the need for additional training for your staff. Here are a couple of screenshots from the data tools that I just mentioned in the previous slide. These surveys include questions on the numerators and denominators data collection practices, along with the answer keys. These are, once again, helpful in understanding that what are your current practices. And as you go through, these are just the screenshots of one page for each of them, CLABSI and CAUTI, and then on the right side, it's Lab ID. But as you go through these, this will definitely help you identify that where are the gaps and what can you do in terms of identifying the training needs for your staff. And then included in the, as I said previously, that we provide you with the step-by-step guidance on how to plan the validation activities at your facility. We will go through some of these recommended activities, and which we combine them either as activities to be conducted on an annual basis, monthly, and some routinely. We recommend that the facility creates an annual surveillance and validation plan. Once a year, definitely make sure to review who are your current partners and recruit new partners as per need. It is important to review and update any of the staff training needs. And the last point within the annual check is that reviewing your facility descriptors. What we mean by this is that if things have changed, if additional locations have been added in your facility, or if there were modifications made to the existing locations, you definitely want to review them at least on an annual basis and make corrections and make sure you map them correctly. On a monthly basis, please determine that the monthly HAI reporting plan is complete And prior to data submission, make sure to run the data analysis checks for any missing, duplicate, or implausible data. The last point, which we call as routine, is what we are not being prescriptive on how often you conduct this. However, we recommend that to conduct these as routinely as possible. Some of these suggested activities include conducting spot checks of whether to track that whether the denominator data collection is being conducted accurately, and also do conduct active case finding. Now we'll go through each of these activities. So let's look at the annual checks. And I know in the last couple of days you've heard this several times to know your protocol inside out. It is very important that the staff who are involved in data reporting are up to date with the changes in the protocols, definitions that are made within the NHSN components every year. NHSN releases quarterly newsletters with the relevant updates, and the staff also conducts regular webinars. So make sure that within the facility, the staff who are involved with data reporting are keeping up to date by attending several of these webinars or reviewing the newsletters. NHSN staff has also been publishing case studies in the American Journal of Infection Control, and reviewing them is very helpful in appropriate case classification. The second recommended annual check that we talk about is completing your annual facility survey. And while you are completing your facility survey, make sure that you have carefully reviewed and entered the data of some of the facility variables. Examples of these include medical school affiliation, number of beds at your facility, location mapping. Because these variables are used as risk adjustment variables for the SIR calculation, we cannot stress it enough that it is important that they are entered correctly. Annually, we do recommend that you review the infrastructure at your facility and decide whether a manual or electronic denominator data collection is justified. If you decide that manual is the best option, and you might want to decide whether you can do it daily or weekly sampling. Review the existing electronic medical record system and the access to IT support systems for regular planned data checks. You might want to also confirm that the existing electronic medical record system is able to link with the laboratory data, and link the laboratory data with the admission, discharge, and transfer data sources. Again, we cannot reiterate this enough that staff who are involved in reporting need to definitely know the definitions. Let's look at some of the CLABSI and CAUTI manual denominator collection. The validation toolkit, which I mentioned previously, consists of surveys with answer keys that could help you assess what are the current CLABSI and CAUTI denominator collection practices. And we recommend that you implement this annually to identify the gaps. We also recommend the last two bullet points in this slide are strongly recommended. However, we are not prescriptive about this because we understand that it is a lot of work. So if possible, validate that the accurate data collection is happening for each reporting location for about a week at least every year. This is only going to ensure accuracy more and more. For all the new personnel at the facility, we recommend that after they have completed their orientation and training, you might want to consider having a competency checklist. Here are a few suggestions as what to look for when you're doing manual data collection, denominator data collection for CLABSI and CAUTI. Are the staff able to correctly define what is a central line? Are they able to apply the transfer rule correctly in even collecting device days? Be sure to look for implausible data points, like, for example, number of patient days being reported greater than the number of beds on a facility. Carefully log the frequency on how often these are happening and the percent of days in the year these tend to happen, especially missing data as well as implausible data. And most importantly, review the results with your staff. Often these are just a simple oversight and they can be very easily fixed. If denominator data for CLABSI and CAUTI are collected via electronic records, be aware that these are commonly inflated unless they have been validated. Hence, while switching from manual to electronic denominator data collection, we do require you to validate the electronic data against the manual data for 3 consecutive months for each reporting location, and to ensure that these counts are within plus or minus 5% of the manual counts. And if this is not happening, you have to work with your IT to correct the errors and revalidate again for 3 concurrent months. And once you're able to get the electronic counts within the tolerance limits of the manual counts, make sure to keep that documentation, because that is often requested if your facility is selected for external validation. So the validators who are coming in might request that, and you be sure to keep that proof. If you're already using electronic medical records, we do recommend that on a routine basis, conduct spot checks to ensure that the current system is performing appropriately. Sorry. For SSI denominator data, it is extremely important to ensure that the procedure data are not missed. And here are a couple of suggestions that we make to ensure that you do not miss. One of the most important resources or ideas is that, it's not an idea, I'm sorry, that identifying all sorts of potential data sources where you could get your procedure data is extremely important. Some suggested data sources are OR records, hospital discharge ICD codes, and then data linkage. Adequate data linkage of multiple sources of data can reduce the missing or over-reporting of procedure data by errors. Here are a couple of common SSI denominator reporting errors that we commonly hear about, come across when we get our questions in the mailbox. One of them is when multiple procedures are performed via the same incision on the same trip to the OR, the facility will definitely have to know very well to determine which procedure to attribute the SSI event to. Another common example that or error that we come across is that if the patient returns to the OR for another procedure within 24 hours at the end of the first procedure, being able to correctly apply the 24-hour rule from the SSI protocol is an extremely important thing that you need to know. Let's look at some of the monthly checks that we recommend. Within the NHSN Advanced Analysis option, there is the Data Quality tab, which can be used to run various analysis checks. These include analysis of duplicate events, implausible data like procedures entered with 0 duration, and missing data. I'm sure most of you are familiar with this page, which consists of the NHSN alerts. Ideally, we would want this to be 0. Let's look at the SSI denominator data validation example. And this is what I'm going to show in this slide is generally nowadays a rare occurrence, but we still wanted to point out that as a possibility. If you see a high SSI incidence rate at your facility and question whether this is really true, you can run the report on extremely high SSI incidence, and you might want to check that whether all the procedures that constitute the denominator data have been accurately included. In this case, only the procedures that resulted in an infection were entered, hence the SSI incidence rates of 100 was observed. Please do remember to enter all the procedures during the month for which the SSI are being monitored during that particular month. Here are a few examples of the different types of possible errors generated when you run a data quality check report, and we're going to take this example for Hospital X. In the first example, the event ID was classified as an outpatient procedure, but the report indicated potential misclassification. At a closer look, we see that the patient admission and the discharge dates were 6 days apart. Hence, classifying this patient as an outpatient patient was an incorrect thing to do. In the second example, the report generated incomplete procedures. The HIST procedure entered was missing information on the use of endoscope, and the COLO procedure was missing information on the wound class. These are risk adjustment variables and must be added along with your procedure data. The third error shows a data outlier. A closer review indicated that the HIST procedure duration was beyond the normal range. So when you run these data quality checks, be sure to carefully look at each of them, each of the reports, and try to analyze where are the errors and correct them. Let's look at some of the ways that a data quality check impacted the facility level SIR. At Facility A, an unusually high COLO SSI incidence triggered the review they noticed that the facility had missed entering 4 months of data on procedures. After these were entered correctly, their complex SSI SIR reduced from 1.6 to 0.9. Similarly, at Facility B, they missed entering 2 months of procedure data. And then after these were corrected, the complex SSI SIR reduced from 1.1 to 0.9. At Facility C, the 3 COLO procedures were missing data on the risk adjustment variables. And when these were corrected, the COLO SIR actually increased from 0.36 to 0.43. This is another example of taking a closer look at the device days denominator data entry errors. NHSN already has built-in business rules which will prevent implausible data entry. In this example, the facility tried to enter 300 Foley days for 250 patient days. The inherent business rules popped up a validation error that the urinary catheter days cannot exceed the total patient days. These are small errors, but being cautious is extremely important. Another example is if you notice that your facility suddenly, the CDI rates at your facility has significantly changed, and you might want to run the analysis of the CDI test method history. If you look at it carefully, that the test method had changed between 3 years, and that would explain that a change in the CDI rates at your facility. Now let's talk about some of the common numerator errors that we come across in CLABSI and CAUTI reporting. Overall, facilities in general are more likely to underreport than over-reporting events. Positive blood cultures are just missed in general to be even reviewed. Users are unable to correctly identify whether the infection was present on admission. And another common mistake, which I'm sure today after the secondary BSI presentation, this is not going to happen, but this is a common mistake that we commonly hear about, is incorrect assigning of the secondary BSI status. Some of the common examples of SSI event reporting. The depth of the SSI is often inappropriately assigned. For example, if it is reported as a deep incisional SSI, but on a closer look at a validation, it actually met the organ-specific SSI. You only assign one SSI event, and that is at the deepest level of infection. Improper use of the infection present at the time of surgery is another commonly noticed error. Most common error is to assign the event as a PATOS equal to yes when there is actually no documentation of an infection at the time of the procedure. And conversely, not reporting an SSI event when an infection was present at the time of the initial procedure. Let's look at some of the routine checks that we recommend. Besides the annual and the monthly checks, we recommend that you conduct a few routine case ascertainment checks. Within the validation guidance, the CDC's external validation guidance includes the medical record abstraction tool, which is useful for case ascertainment. Facilities could use these tools to identify their ability to accurately ascertain cases. We're not being prescriptive on how frequently you should do this. However, we recommend that as routinely or as frequently as possible, you use these medical record abstraction tools within your team to identify how accurately the team members are able to assign the cases. And we recommend that you do this with multiple reviewers to check for inter-rater reliability. And when cases are missed, investigate why and how to fix it. Here are a couple of screenshots from the medical records abstraction tools, which can be found within the external validation toolkit. Few suggested routine checks would be reviewing the positive blood and urine cultures, conducting spot checks on denominator reporting. Another feature of the data analysis tab is the ability to run longitudinal analysis and assess the patterns of errors. Longitudinal data can be run for either numerators, denominators, or overall rates, and this could be run for location-specific or overall for your facilities. Here is just an example of a plot of longitudinal trends of urinary tract infections by the ward location. Now, this is just a fake data from the NHSN, and this does not include all the months of a particular year, but what I'm trying to help you understand is that when you run these longitudinal plots for event data and you see if there are certain spikes for certain months, or for certain months you do not see any events, that should trigger additional looking into like whether the data that was reported, was it correct, or what happened. So what can you do at a minimum at your facility to assure that your data is complete? I've listed a few of the examples for completeness of numerator data in the slide. For example, for CLABSI and CAUTI, review every possible positive blood and urine culture as candidate events to rule out the possibility of a case. For potential SSIs, it is important to identify and review all the post-op patients and hospital readmissions. Just reviewing the positive wound cultures, be aware that you're most likely going to miss 50 to 60% of the SSI. Hence, during the daily hospital rounds, it is important to identify any potential infections that are not resulting in positive cultures. Additionally, we do recommend that your facility, if they already do not have an existing post-discharge surveillance, to set up that. For lab ID events, FACWIDE in, make sure to assess and review all the lab test results from inpatient, emergency, and observation locations. Similarly, to ensure that the denominator data is complete, make sure to review the presence of either the central line or catheter for every positive culture and ensure that the collection of the device days are complete. For SSIs being reported, ensure that you have gathered a complete count of the procedures based on the ICD and CPT codes for the particular month that you're following. While reporting FACWIDE-IN Lab ID events, ensure that all patient admissions and encounters from every location have been included. It is very important to realize and accept that the IP cannot do the complete surveillance and validation alone. Hence, building coordination between partners, stakeholders, as well as various hospital units, services, and disciplines is extremely important to be able to accomplish all these tasks. IPs do need protected time for the prevention activities. Hence, coordination for support is extremely important. Now, who can help support the IP while doing all of this work? Here are just a few examples of possible partnerships. While monitoring CLABSI and CAUTI, you could have trained CLABSI and CAUTI monitors within different floors, wards, who could work in collaboration with the IP so that to ensure that the data collection is complete. Work with the IT to review that the electronic data downloads and build that partnership ahead of time. While monitoring surgical site infections, we recommend that build partnerships with or collaborations with the surgical, clinical, and the ward staff, as well as the medical records. While monitoring FACWIDE-IN Lab ID, again, we talk about the trained Lab ID monitors at different locations. Work with the IT to ensure that data linkage between the laboratory and ADT records is complete. And these are just suggested examples. By no means are these comprehensive. So you have to work with your facility and identify all the potential partnerships which will work best for your facility. So bringing it all together, what can validation help us with? We looked at data completeness, and that will happen by double-checking all candidate events until they are ruled out. It is important, and validation will increase the coordination by focusing and building partnerships and build the overall confidence and ownership on your own data. To be able to build confidence on your facility's data, it is once again necessary that the staff that are involved in reporting are up to date with the surveillance methods and definitions and are able to apply them correctly. Remember that facilities are held accountable for knowing and applying these definitions correctly. And hence, if you have any form of ambiguity, please do reach out to us through the NHSN mailbox so that we can help you. We stated earlier in the presentation that internal validation is a routine process built in at the facility level. I want to point out to an additional resource which is building the partnership with your state health department. Your state HAI coordinator can help you in conducting internal validation. This is an existing process already in several states. The state HAI coordinators are routinely conducting data quality checks. They reach out to the facilities and collaborate with them in reducing the data errors, and they often do this before you have your data reporting deadline for the quarter, because once that deadline is reached, there's nothing really that can be done. So based on the 2016 annual facility survey, more than 70% of the state health departments have actually received access to the data from their reporting facilities. This does allow the state HAI coordinator to run data accuracy checks and work with the facility. So we strongly suggest that if you are in a state where this is not an existing, already established structure, you might want to consider providing the access of your facility data to your state HAI program. This graph shows that the percent of state health departments that do receive the data from the reporting facilities, and what percent of them have conducted at least 6 months of data quality checks on the data reported by their facility in 2015. There was a wide range. More than 70% of the state health departments have conducted at least 6 months of data quality checks on the CLABSI data, whereas 57% of the states conducted data quality checks on their MRSA data. This is really a wide variation, and we would like this to go up, preferably 100%. Among the states where the HAI coordinator was able to routinely conduct the data quality checks, more than 82% of the state health departments did contact their facilities and work with the facilities in the correcting the reporting errors. 82% is definitely a very encouraging number. However, we still push for 100%. So what should trigger additional data quality checks outside of the annual validation plan? If there were new patient care locations that were added at your facility, or if there are any modifications made to the existing locations, be sure to, in the beginning of the year, to correctly identify that these locations have been mapped. If there were modifications made to your electronic medical record system, or if you just started getting a new electronic medical record system, that needs to be validated. And if you see any unusually high incidence of events, make sure to check whether the denominator reporting was complete, were all the risk factor adjustment variables, were they entered correctly, and was there a change in certain testing methods? Hence, to summarize, we all know that credible data is vital to HAI prevention. And listening to our CMS colleague this morning, we all want to be publicly looking good and making sure that we get the reimbursements and don't miss out over there. Ongoing validation is the key towards improvement of all the prevention practices. And regular ongoing validation and internal validation will overall improve the results on the external validation. I didn't promise you in the beginning that I'm going to finish early. So thank you. I'm open to taking questions. Are there any questions?
Hi, my name is Avi. I'm from Maryland. My question is in regards to the denominator validation. So we recently got a new electronic system, and in our old electronic system, we did the standard validation process that was recommended, and we were pretty much confident with those numbers. Now that we got the new electronic system, everybody is trying to get hold of the system with the documentation, and from the nursing side, we are having some issues going on. So we are trying to resolve that. That being said, when we did our initial validation, we identified that there was 50% error in the documentation portion with the manual validation when our ICPs went onto the floor and validated the data. And after that, we did some work and worked with the nursing and got everything squared. That being said, we did the second validation after 3 months. Of all this work, and what we identified is that we were able to get about 95% confidence in our data with the validation that we did. So that being said, now I heard that we did not do definitely 3 months validation when we did the second time, but given that our facility is so huge, we have about 50 units and 1,000-bed hospital, what is the optimal time that you recommend us to do the validation process? The manual validation, meaning we pull the data from the electronic systems separately and somebody physically going to the location at a specific time window and trying to capture those manually on a paper and comparing those side by side, basically. So this is really resource intensive.
Let me understand this correctly. So you had an existing manual data collection process, you changed to a new electronic method. Then while you were conducting the validation for electronic data, you noticed that the manual collection had more than 50% error. Is
No,
that
no,
correct?
no. So we moved from one electronic system to the other electronic system.
Okay.
The first one, we did the validation when we got the system probably 6-7 years ago, and we have been doing the regular validation checks. We were confident with that data, but now that we got the new system,
Okay.
our numbers tend to be trending towards downward.
Right.
And now, when we did the manual validation to compare this new system, our their numbers are lining up pretty much good. But we did not do all 3 months validation that you're recommending for the electronic system. So, do you expect us the facility to do the 3 months validation?
Yes, especially if you're seeing such wide error. We would recommend and require actually that, especially even though you're moving from one electronic method to another electronic method, and before you do that, you make sure ensure that the second method is actually still collecting the data within the tolerance limits.
Gotcha. Thank you.
And we definitely require you in that case to perform that for 3 consecutive months.
Okay. Thank you so much.
Mm-hmm. Any other questions?
Hi, I'm Roger from Massachusetts. Along the lines of doing the validation of this, can there be a sampling, or is this 100% count in validation? In other words, can we sample 1 unit per week for 3 months? Or I know the smaller the number, the harder it is to make that 95% too. How do you recommend this be done?
For the denominator data validation,
the
when moving from
denominator, right.
manual to electronic,
That's
then
right.
it needs to be done for each reporting location.
100% of lines, or can it be a sampling?
100%.
Have to count every day for 3 months, every single line
Right.
for every location.
Right. That is important, and
Okay.
because it is a difficult process, but it is something that is required.
Okay, thank you.
Mm-hmm.
Just want to clarify.
So I hear a lot of murmuring in the room about that. You would probably have been doing annual collection anyway. So it's not that we're asking you to do anything additionally. We're saying you have this standard, this gold standard, which is manual collection. Before you move to something else, you have to make sure that it's just as good as the other. And we've heard from lots of facilities that have moved from one electronic to another electronic where they discover problems. And we've also heard that a count may be good in one location but not another location for various reasons. So that's why we do say every location that you're going to do this in, you have to validate it for 3 consecutive months. And we've had some questions recently about whether or not they have to be consecutive months. Our intention is that they're consecutive. It doesn't technically say that in the protocol. It will say that in the future. That's where we're at. And it's because we know that there are problems out there in how the data is collected.
Any more
I just had one question.
Sure.
So for my surgical denominators, we used to report it via CSV file and import, and then we ended up switching to a electronic for the surgical, and then we went to CDA architecture. So the way they built it, what I was noticing for this past year, we had issues with mapping procedures because I think they built it wrong off of preference cards versus the coding. So basically, I've been validating for a year for this thing with our procedures. So supposedly CDA architecture is supposed to be a lot easier than CSV importing, correct? When you're importing your surgical procedures?
Comparison between a CSV and CDA. So CDA is supposed to be a lot more easier, so it should have been accurately collecting the data as compared to a CSV. And they've been conducting validation for almost a year, and they haven't been able to work things through. Right, so please do send us through the mailbox, and we'll be happy to definitely look into it. Yeah, right.
We have one question, Suparna, from the mailbox that we want to address. Please clarify, one of the minimum standards for SSIs just indicated daily rounds, the floors to look for infections that are not cultured. That is not included in the SSI protocol and not part of our surveillance. I consider that this was a minimum expectation rather than an option.
That's correct. So that is a minimal expectation, and these are recommendations that we are providing so that you make sure that that events or procedures are not missed. And yes, if only wound cultures are what if we suggest that that's the minimum, then you're most likely going to miss 50 to 60% of the SSIs. So we do recommend that other potential sources, looking at post-discharge surveillance, post-op patients, readmissions, looking at other possible ways so that you are able to capture 100%. And so it is really a minimal requirement, basically trying to look at every possible source. Thank you.
Okay, we're over the hump day. We can get out of here a little bit early today, but I do need to let you know about a couple of things. I don't know if you all have seen, but NHSN is back up and running. You can enter data. However, the training server that holds our website or our worksheet generators and our calculators is still down. The email that was sent out says that clearly, but we are being inundated with people asking us, saying that they can't still access the worksheet generator. So I'm asking you as our partners, if you have people at home that are asking these questions, tell them that yes, the worksheet generators, that server is not yet up, and it will be, hopefully, we're hoping within 5 days. And as soon as it is, we will be sending out an email and letting everyone know that. So for those on the web stream also, please wait till you're notified that it's been restored before trying to access this. And please don't send us emails saying that you can't get to it. Nope, we know that. We're trying to keep up with stuff. So if you are also hearing people here in the room that your partners are having trouble accessing the web streaming is working. For some, there's a Windows Media. There are 3 different types of links that are available. Some people have problems with the Windows Media. So if that doesn't work for you, please tell them to try one of the other links. But the web streaming is working. Today, remember as always to scan out when you leave, fill out your evaluations. Tomorrow we start at 8 a.m. Tomorrow is SSI and MRSA, BSI, and CDI Lab ID event day with analysis. Please put your clickers in the orange baskets, and I think that's it. It's a wrap. Thank you.